Hi everyone, welcome back again to my channel. Today I'll be talking about female infertility. If you can recall, we discussed male infertility yesterday and we agreed that infertility is inability of couples to achieve pregnancy after 1 year of unprotected adequate sexual intercourse. Now we divided the contributing factor to infertility into male, female, combined female and male, and unexplained. And yesterday we said that male factor infertility contributes about 30 to 40%, then female factor infertility contributes about 30 to 40%, then combined female and male factor contributes about 10 to 20%, and unexplained cause contributes about 5 to 10%. Today we'll be talking about female factor infertility. Now, why it's necessary for us to examine and evaluate the man before the woman is because it's easier and simpler at evaluating the man before the woman. All we need is the sperm, the semen collection, and physical examination. So if these are okay, we allow the man to go. Now let's talk about the woman. The woman has a barrage of investigations to be done, or barrage of causes to infertility by the woman. It could be from the uterine factor, could be from the cervical factor, could be from the tubal factor, could be from ovarian factor, could be from the peritoneal factor, and it could even be from the general well-being of the woman, or even other things from even the hormonal system of that woman. So these are what I will take one after the other. Today we'll be talking about the cervical factor and the uterine factor as a cause of infertility to the woman. So we'll be taking the cervical factor before the uterine factor. Cervical factor infertility. The uterine cervix capturing the sperm, and even in capturing the sperm after intercourse. So what it does is that it captures, it nurtures and transports the sperm from after intercourse into the uterus and the fallopian tube. It also aids in capacitance of the sperm. Now, it releases only the matured sperm into the uterus and cervix, into the uterus and fallopian tube for fertilization. If there is any problem with the cervix, either that the mucus is not normal or that the cervix is stenosed or closed by stenosis, whatever the cause be, it can lead to cervical factor infertility. It's been said that cervical factor infertility contributes about 5 to 10% of the female factor infertility. So let me explain again the cervical mucus. After menses, the cervical mucus is small. It's not copious, it's small and it's thin. The effect of estrogen is still working on it, but during ovulation, the effect of estrogen is more prominent on cervical mucus because it's preparing the sperm for transportation into the uterus and fallopian tube. What it does is that the cervical mucus becomes thin, stretchy, elastic, and alkaline. This nature helps in transportation. They form a micromolecules among themselves. So that even if you get the cervical mucus at the time of ovulation and place it on and smell it on a glass slide under the microscope, they form a fan-like feature, like I'm showing above. So it will help in transportation of the sperm cells into the uterus and cervix for fallopian tube, for fertilization. If there is any abnormality with the cervical mucus, there may be a problem in that process of capturing, nurturing, and transportation of the mature sperm cells into the cervix, into the uterus. So cervical mucus is very, very important. Between 24 to 48 hours before ovulation, you will see the cervical mucus copious, thin, elastic, transparent, that it can stretch so much. So So these processes help in sperm maturation and transportation for fertilization. Now, after ovulation, the cervical mucus becomes opaque, hostile, and may not allow sperm cells to migrate. So at the time of ovulation, for those that want to conceive, it's better that sexual intercourse is maximal at that point if the male parameter, sperm cell parameters are within normal. Now, the next thing is the cervical stenosis. If there's anything that constricts the cervix, preventing it from opening, it could be congenital, it could be acquired. It could be congenital. The person came with it, but common ones to have is the acquired method, and they can come as iatrogenic form. Maybe during surgery, there may be injury to the cervix, and after repair, the cervix heals by fibrosis and may become stenose. For those that have vesicovaginal fistula, there's what we call justa cervical, intra-cervical fistula. So after repair, that site may become fibrosed and become stenosed. So it will be difficult for sperm cells to migrate. Now, there are others that from termination of pregnancy, especially in the tropics, where people will go to chemists to quack to get their termination of pregnancy. And they may do what we call dilatation and curettage, and in the process, damaging the cervix. And so it will not heal by fibrosis, and it will not stenose. So it may be difficult for the sperm cells to migrate. Instead of hypoestrogen, the cervical, there may be cervical stenosis, and this may affect migration of the sperm cell. So these two are the commonest cause of cervical factor infertility. Now I'm going to talk about the uterine factor infertility. Remember that the uterus is where everything that happens. The mature cells are released into the uterus and they migrate to the cervix, to the fallopian tube, migrate to the fallopian tube, where they mature. The egg is released, they capture the egg, and the mature sperm cell that is ready for fertilization comes into that fallopian tube to fertilize the egg, the ova, before transportation back to the uterus for it to implant. So uterine factor infertility can also contribute to problems with infertility in the woman. The problems of the uterine factor infertility could be acquired or congenital. The congenital problem starts from abnormalities in the development of the Mullerian duct. The Mullerian duct develops during in utero, when the baby is still in the womb. So when the baby is still in the uterus and there's abnormality in the development of the Mullerian duct, there could be total absence of the uterus and vagina. And when there is total absence of the uterus and vagina, what we know as Rokitansky-Costa-Hauser syndrome, with the woman, the person will develop as a lady, but there is no total absence of the uterus and vagina. So that could lead to infertility. If it now ranges from this total absence of uterus and vagina to minor Mullerian problems, like problems with the septa. There could be intrauterine septa, longitudinal or transverse, or minor abnormalities in the uterus. This could affect fertility of that woman. But the more commonness is the total absence. When there is total absence, there is no place for intercourse and there is no place for fertilization. So these are congenital. Then the acquired causes of uterine factor infertility ranges from drug-induced uterine malformation to Asherman syndrome or uterine synechia to endometritis and to even leiomyoma, that is fibroid in the uterus. Now I'm going to take it one after the other. Remember that drug, diethylstilbestrone, that was given before to pregnant women for management of nausea and vomiting in pregnancy, where most babies came down with absence of the limbs, both the upper limbs, the hands and the legs. So that drug is associated with abnormalities in the uterus, some to the extent of developing septal abnormalities, problem with the tubes, problem with the cervix. So this can lead to uterine factor infertility. Now, babies exposed, not actually the mother, the babies that were exposed to that drug in utero had issues with infertility, and that was uterine factor infertility. Now to Asherman syndrome, some women will present with problems, maybe miscarriages, and on the process of doing dilatation and curettage, on the process of curating, the endometrium is curated, is removed, and the woman may now develop Asherman syndrome. So Asherman syndrome or uterine synechia, she will stop seeing her menses, and if you do hysterosalpingogram, you will now see that, or even hysteroscopy, you will see that the uterus is matted together because the endometrium is already removed, or maybe trauma to the endometrium will lead to synechia. Now, for some others that had fibroid surgery, it's possible that, and especially for submucous fibroid, if keeping the endometrium after it is breached, if it's not kept patent, the woman may develop Asherman syndrome or uterine synechia. The syndrome has every other things. There are some other women that had infection after delivery or after post-abortal complications with the sepsis that followed it. They may develop uterine synechia, and that will lead to uterine factor infertility. Now, we are going to endometritis. Some women have that delivers in unskilled birth attendant homes. Some of them in the tropics, gloves are not even used. Latex gloves are not even used. Talk more of in a sterile environment. And after delivery, you see them develop endometritis. Infection into the uterus may lead to some problems in the uterus, and the woman will have uterine factor infertility. So uterine factor infertility contributes about 3 to 4% of female factor infertility. So it is very necessary that for every woman that has infertility, they are evaluated very well. Now let's come to fibroid. Fibroid from studies have not been shown to be direct cause of infertility. However, if every other cause of that infertility is not seen, and fibroid is the only thing that is seen in that woman, except especially submucous fibroid, that should be considered as the reason for that infertility. Remember, I said when every other thing has been evaluated. So there are some reasons why fibroid may be the cause of the infertility. One is depending on its location, the size, and the distortion it gives to the uterus. So when, let's assume that there is a submucous fibroid in the woman. Fibroid can be submucous, it can be intramural, it can be subserosa, and it can be pedunculated. So submucous fibroid is the one that stays in the endometrium where the baby stays. So if there is submucous fibroid that is distorting the surface of the endometrium, it may be difficult for fertilization to talk more of implantation, because the distance from where the sperm will travel to the fallopian tube becomes longer. It can also be that it will not allow the fertilized ovum to implant well, so it may distort the surface of the endometrium, leading to uterine factor infertility. Now, remember we said submucous fibroid, the location now. If the fibroid is located at the submucous area or is located on the tube, there's some fibroid that you open up and you see that it's on the tube, obstructing the tubes. There is no way the sperm cell will migrate to fertilize the egg. Remember, the egg is fertilized at the tube. So any fibroid distorting the tubes or closing the tubal patency will lead to uterine factor infertility. Now, depending on the size, if the fibroid is so huge that is occupying the whole space of the uterus, especially the submucous fibroid, if it's so huge that there is no space, number one is that it will prevent sperm from migrating to meet the egg. It will also prevent the fertilized egg from implanting. If the fertilized egg tries as much as possible and implants, it will lead to recurrent miscarriages because it will not allow that pregnancy to grow well. And remember, fibroid grows with pregnancy because it's hormone dependent. It feeds on hormone. So when every other thing has been evaluated, and we can't say this is the cause of this infertility and it's only fibroid that we see. We cannot think of the ways the fibroid will cause infertility. So female infertility can be from the cervix and the uterus, can be from the tube, can be from the ovary, can be from the peritoneum, can be from the general well-being of the woman, or it can be from the hormonal system of that woman. This will be taken care of. Episode 1 today has taken care of the cervix and the uterus. Tomorrow we'll come back and do the fallopian tubes, and the next time we are going to do ovarian. We're going to take it one after the other. Please keep a date with me. Thank you for watching to this point. If you have not subscribed, please hit the notification button now. Follow me on Facebook at OBGYN Talks with Dr. Adazion. Then subscribe to my YouTube channel at Dr. Nkiruka Bridget at OBGYN Talks with Dr. Adazion. I'm also on TikTok. I'm also on Instagram with the same name. God bless you. See you next time. Thank you.